And I must thank Dr. Litta, whose excellent organizational skills are there for all of us to see. She's been very kind, and she's been in touch with me for more than 3 months, if I might say. And I would also like to thank Dr. Tony Fernandez for the kind words that he spoke about my father-in-law. He always used to remember this place and Dr. Tony with, he had always very fond words to speak about. And my husband and his brothers recall very fondly, they used to drive down from Bangalore to the CMEs that Dr. Fernandez used to organize. They have very fond memories of those. Thank you, sir. Thank you. So I'll go about my topic, which is medical management of glaucoma. So like all the speakers before me have told, the glaucoma is an individual disease. So it is something that you don't have a cookie cutter approach to. Treatment should be tailored to the patient and his or her disease process. And one should not forget that it is lifelong. The treatment has invariable side effects and definitely cost effectiveness issues. So I would say the institution, modification, and maintenance of medical management of glaucoma is as much an art as it is a science. As you go along, you develop an instinct in addition to the science, and that is what helps you. So here I will go about this talk with question and answer kind of a format. So the common questions which people ask me, I'm going to go about and answer these questions. So the first thing, should we establish a target IOP for every patient we treat? The simple answer is yes, because unlike blood pressure, the IOP is not a set level where below a certain point it's normal and above a certain point it is abnormal. Each person, the susceptibility to damage varies. So definitely yes, we should establish a target intraocular pressure. The second question, how do you set the target intraocular pressure? You look at the IOP level before treatment, the stage of glaucoma. That is, if the stage of glaucoma is very early, then a 20% or so reduction may be adequate. But if the stage of glaucoma is very advanced, more than the percentage reduction, one would want to bring the pressures to less than 14. So the stage of glaucoma is important. Third, the rate of progression. So this target is not a set number. You need to change it as you go on following up the patient. Say you set a target of 18 or 16 for a patient, but this patient is still progressing during follow-up, you have to revise it to lower levels. So the target IOP also depends on this. Age and life expectancy. So I would not be very aggressive in a patient who is 80-year-old, has a comorbidity like a untreatable cancer. In such a patient, I may not even treat the patient. So age and life expectancy have a role. And most importantly, other risk factors. The very significant one is pseudoexfoliation. So patients with pseudoexfoliations progress very fast and progress very badly. So in these patients, be very, very wary and have your follow-up periods closer and set lower target intraocular pressures. The next question, do I use a percentage reduction or aim towards an absolute number? So here again it varies. So when you're starting with a pressure like 38 or 40, definitely it is not percentage reduction. So here, if the damage is very early, you will have a modest target of about 20 or less than 22 or 23 probably, and follow up the patient. But say a patient who has a normal tension glaucoma, say the patient starts off with a pressure of 14 and you have damage. It's very difficult to achieve 20% or 30% intraocular pressure reduction. So some reduction is enough, and you don't have to strictly follow that 20% reduction. In patient with advanced glaucomas, no matter where you start, you may start at 35, you may start at 40, where you have fixation threatened and double arcuate scotomas, I need to bring it down less than 14. So there it is an absolute number. So again, this varies depending on the clinical context. So the role of diurnal IOPs, we spoke about it in the morning, so I'm not going to go into that in detail. Pay attention to intervisit IOP fluctuation. So in one visit, if you find that the pressure is 12, next visit it goes up to 18, and again the third visit it is 12. There's something else going on. Patients who have higher intervisit IOP fluctuations tend to progress. They are the ones who are more likely to progress. So keep that in mind, factor that when you are looking at the patient. Certain general principles, assess each eye individually. Very important, single IOP measurement is insufficient as a parameter to base treatment. This might be somewhere else which is done. They may come with a report which says 30 millimeters of mercury. How was it done? Was it eye care? Was it air puff tonometer? So you should not base your treatment on a single IOP measurement. Have at least 2-3 readings. Use the least amount of medication necessary to achieve the therapeutic response, and if you want to, you can consider a therapeutic trial in one eye. The next question that you would ask is, what is the first line? So here again, it is dependent on the clinical context, but generally I would say prostaglandin analogues are the first line when you are looking at medical management of glaucoma, and many of these PG analogues are also available at lower cost to us. So you can consider that the cost effectiveness issue is not as much as when we started off. So PG analogues, but then this is depending on the patient. You can have situations where beta blocker is the first line, and the other line of drugs can also be first line. So how would you go about? You start monotherapy. If you have achieved 20% or more IOP reduction and target IOP is reached, you continue to monitor IOP, disc and visual fields. If it is greater than 20% reduction and target is not reached, then the drug is effective. So here you can switch or add medications depending on what is possible for the patient. But if there is less than 20% IOP reduction, when you check the patient after starting the medical management, stop the medication, don't add. So many times you have patients who are on 4 or 5 medications. People have not assessed the efficacy and they keep on adding. So don't do that. If the medication is not effective, remove that medication. Make a note in the patient's file and don't use that medication again. So this way we can avoid this polypharmacy that we frequently do. So these are all the drugs that are available to us. I will not go into them in detail, but be aware of the expected percentage of IOP reduction from baseline. So here, as you can see, the PG analogues, they are the ones which give you the most IOP reduction, followed by timolol, and the others, the carbonic anhydrase inhibitors and the alpha-2 agonists are a little lesser. So this you should keep in mind when you are considering which drug to start. So fixed dose combinations. So definitely fixed dose combinations are advantageous when we are treating patients with glaucoma, increased compliance and convenience to the patients. One might ask me, like, you started a prostaglandin analog, it is not efficacious, so when you switch, will you directly switch to a fixed dose combinations? The answer to that is yes, I do that. Theoretically, yes, one would like to establish efficacy of either dorzolamide or brimonidine and separately timolol before going on to a fixed dose combination, but there are constraints of time, number of visits for the patient, so it's not wrong to consider that fixed dose combination as a single entity. Okay, so what should I first add to a PG analog? Beta blocker. And what should I first add to a beta blocker? PG analog. So, and depending on the context, either brimonidine or brinzolamide, dorzolamide. So, do you switch between prostaglandin analogs? Yes, we can switch between prostaglandin analogs. So, say you started the patient on latanoprost, patient's IOP is not coming down. Sometimes there are latanoprost non-responders who respond to either travoprost or bimetoprost. So, yes, you can switch between the in between the class only. And sometimes you have the target as 14, you have come down to 15 or 16, you want that extra millimeter, bimetoprost switching can definitely help, that is 0.03%. So what are the role of Rho kinase inhibitors? These are the new kids on the block, ripasudil, netarsudil. I would say these are used more as adjunct. And the limitation with this is the side effect, the dose-dependent conjunctival hyperemia and the subconjunctival hemorrhage, allergic conjunctivitis, which many times starts 12 weeks after the initiation, and corneal side effects. And it is touted to be endothelial friendly, but I'm seeing in my own clinical practice that the corneal side effects, the surface side effects of these drugs are far more to make these a routine drug, or even I never use it as a single drug or a first line drug. It's always a last ditch measure where you are trying to buy some time for surgery. Should miotics be used today? Yes, in certain situations pilocarpine can be the only drug which brings the IOP down. Play to iris and certain pseudophakic patients, pilocarpine you should keep in mind, that's one more drug in your armamentarium. What are the precautions? Peripheral retinal examination should be done before you start the patient on pilocarpine. So let's go through a few case scenarios where I will show you certain side effects which are missed out. So this is a patient of mine, a retired bank official who has been following up with me for a long time, almost 10-15 years. He was on timolol, dorzolamide and travoprost. He developed a significant cataract and I took him up for cataract surgery, phaco and foldable IOL. On the OT table, we have an anesthetist on call for all of our cases. It's monitored. The anesthetist pointed out to me that the heart rate was 45 and patient had no cardiac problem. So beta blockers are common causes of sinus bradycardia. So remember this for all your patients who are on beta blockers, check the resting heart rate, because independent of everything else, decreased blood flow is also a risk factor for progression, and our treatment itself should not cause this, and this can cause lot of problems for the patient, giddiness and hypotension. And there was a patient of mine who said, I will not come the next visit because I'm scheduled for a pacemaker implantation. And I said, you are on timolol, let us first stop that, and later on you can go back to your cardiologist again after 3 weeks and then go ahead with this pacemaker. Stopping the timolol was enough and the patient never needed a pacemaker. So don't underestimate this. Check and elicit symptoms. Observe patients for breathlessness or wheeze. They don't volunteer that they have asthma or asthmatic tendency. They say that they had it and it went away, but you should observe the patients. And this is another patient of mine, 75-year-old gentleman, a retired IAS officer, hypertensive, diabetic, moderate glaucoma, treated with latanoprost. And we added brimonidine because he was not eligible for timolol. So after a month later when he comes, the patient is usually very smartly dressed with a tie and is very, talkative. This patient has become listless, communicates lesser, he speaks only in single syllabus. And the wife says, I don't know, doctor, nowadays he's very withdrawn. So the CNS side effects of brimonidine cannot be underestimated, especially in the elderly age group. These are all real patients of mine. So you should be on the lookout for it, stop it if that kind of a problem occurs. Allergy is very common with brimonidine. Keep looking out for this. The treatment of such allergies is not steroid. Let me underline that. Removing the medicine is the treatment. So treating with steroids can be counterproductive, and remove the offending agent. Third patient, diagnosed glaucoma, started on latanoprost, came back to the clinic 5 days later. What did I find? A reactivation of a herpetic keratitis. So PG analogs can cause reactivation. Be careful. Look for corneal scars and vascularization, and be on the lookout for this. This is a patient who was operated for a very advanced glaucoma, one-eyed patient, AGV with scleral patch graft. He was following up with a local doctor, but after 2 years, the local doctor referred him back for query endothelial decompensation. So this is the patient. You can see these lesions here. The tube is in place. But on closer look, you see this. This is nothing but honeycomb keratitis, which is a side effect of ripasudil. So be on the lookout for this. This is not endothelial decompensation. This is just a corneal side effect of the Rho kinase inhibitor. Another patient, a lady, 50-year-old, recurrent episodes of anterior uveitis. She is a steroid responder. The IOP was 38 millimeters with maximal medication. She was intolerant to Dimox. And ACTAP was positive for CMV, and all other investigations were normal. She was on systemic Valgan, cyclovir, topical steroids, homotropin. Uveitis completely resolved, but the IOP remained in the 30s. So as the patient was unwilling for surgery, after discussing with the patient, I added bimetoprost. Here you can see a small hemorrhage which happened after paracentesis for PCR. That is a sign in such patients. So immediately after starting bimetoprost, you can see that the anterior uveitis worsened. So in patients with uveitis, though I would say PG analog is not contraindicated, when the eye is quiet, you can consider it. Be on the lookout for reactivation. So in secondary glaucomas, uveitic, post-KP, post-PK surgery, the PG analogs come down in your list of medications. The other medications are preferred. And post VR surgery, post SOR, here there is no problem in using the prostaglandin analogues. In neovascular glaucoma, PG analogues again have a lesser role to play. Systemic acetazolamide, yes, we would use it as a temporizing measure, not as a long-term treatment. What are the precautions you would take? In the elderly, be wary of electrolyte imbalances. And the other question is, are topical carbonic anhydrase additive to systemic? So when a patient is on 3 tablets of Dimox for a short period of time, the topical dorzolamide or brinzolamide doesn't do anything in addition. So keep that in mind. And the long-term protocol, see, many times you find certain patients who are unwilling for surgery, where you have to maintain them on half a tablet of Dimox 2 times a day for a longer period of time. In such patients, monitor the electrolytes and the platelet count and make sure that they report side effects to you. So typically, this is how we diagnose glaucoma. Patient comes for a routine visit, IOP is high, distant field shows changes. So we have detected glaucoma early and we ask the patient to put drops and all that. Have we won the battle against glaucoma? No, because here patient communication, the doctor-patient communication is something that you can never, ever, ever underestimate. Only 40 to 70% of our patients follow medication schedules. So assume that non-compliance is an issue. Okay, and elicit it in each of the visits that the patient does. So how do you assess? Use specific questions. Do you have any problems? Do you tend to miss drops occasionally? Is it hard to remember? Did you put the drops in today? What time did you put the drops in? How long does the bottle last? When did you buy your current eye drops bottle? Non-judgmentally asking the patient and eliciting the answer, you can reiterate the importance of putting the medication and convert the patient into a compliant patient. Employ methods to teach drops application. Teach your assistant to, tell them how to put the drops. We did a small study with one of my fellows where he assessed the drop application method for patients who had long-standing glaucoma, who are on topical treatment, topical eye drop treatment. And he used to record the video of the patient putting the drops before they came and saw me. Ask them to put the drops in front of him, record the video. I was shocked to find my one-eyed advanced glaucoma patient. He was closing his eyes and applying the drop. So these things are so, unless you check, you never know. So certain patients have this misconception that the drop should fall on the black of the eye only. So they waste the bottle. Before, 1 month it should last, it hardly lasts few days for them. So please check drop application. If you have a good glaucoma practice, consider the role of a disease counselor. And the written prescription, avoid using abbreviations, use generic names, write clearly in English or even in local language. Educate, reiterate, verify whether they've understood. Every visit, this is something that you need to do. Glaucoma in pregnancy, what medications are safe? The simple answer is in first trimester you want to avoid. IOP naturally comes down a little bit during pregnancy. So patients who have very early glaucoma or ocular hypertensive, you can even avoid all the medications in the first trimester. In the second trimester, you can give alpha agonists, they are safe. And prostaglandins, there is divided this thing, but in the second trimester, definitely it can be used. Third trimester, prostaglandins are implicated in premature labor. And just before childbirth, you're supposed to stop beta blockers and alpha agonists because of the respiratory depression in the children. So in short, I've tried to cover common questions that one would ask. Medical management is a wide topic. If you have any questions or anything else you want me to tell you about, please let me know. Thank you.
Thank you, Dr. Gowri. That was an excellent presentation. Actually, many of our doubts also were cleared. And the importance of checking with the patient about the last drop applied, how they apply the medication, and how long the bottle lasts and all that. It's very important. Actually, many a times you find out that the patients are not putting drops from all these questions only. And Dr. Gowri has very clearly expressed how to examine and how to find out whether the treatment is proper in a patient, because that's a very important thing. to prevent progression in glaucoma. Thank you, Dr. Gowri.
You.
And Dr. Devendra, any comments?
No, I think it's an excellent talk. Madam covered all the points. I will have one question, ma'am. Which ryokinase inhibitor do you consider, either repasodil or netarsodil? And as some of the practice we have seen, repasodil really works in certain corneal cases, not all. So what is the choice when you come to ryokinase inhibitor, either repasodil or netarsodil?
Definitely, ripasudil has a slightly more tolerability profile when compared to netarsudil. So even when I am considering a rho kinase inhibitor, it would be ripasudil first and netarsudil later. There are some of my patients who are on long-term ripasudil, but I can count them on my fingers. And my corneal colleagues also use ripasudil, sometimes with in Fuchs endothelial dystrophy. But then these are all few and far in between cases. So I still have to learn more about the endothelial friendliness of this. Though it is scientifically said, whether it is really so in the actual clinical practice or not is something that we'll have to see. The surface issues are very bad. Once they start developing the allergies, they become allergic to all the medications that we are giving them. So warn the patient, even when you are starting the drop, that there may be this problem and you come back. It is a good addition. We have one more drug, but then it's not what I thought it would be, or it's not like a meaningful addition to our
Thank you, Dr. Gowri. Also, that case of that CNS depression with brimonidine was very nice. I actually had experience where, before this brimonidine brinzolamide combination came, that patient was very happy on brimonidine and brinzolamide, but when I switched to the combination, they got side effects because the combination had the higher concentration of brimonidine. So immediately it was, the patient just said he just lie down, and when he gets up, he was just feeling so dizzy. He couldn't even stand up. So I had few patients with those side effect due to the higher concentration of brimonidine who were previously happy with the lower concentration separate drugs.
Correct.
Thank you.
One more doubt, madam. This preservative-free preparations, what do you think about them?
They are definitely helpful, ma'am. There are a small percentage of my patients who are very sensitive and cannot tolerate these topical anti-glaucoma medications. So in that, the newer preservative-free bottles, definitely I think the bottle is a little different, the novella technique or whatever, but definitely it helps and patients tolerate it. Saflutan used to be a drug which was tolerated very well. A patient who would not tolerate latanoprost, bimetoprost, travoprost would be very happy with saflutan. I am so sad to see that drug go. I hope someone will make saflutan or tafluprost, generic versions, and that is again available to us. But preservative-free formulations, definitely yes. I use them in my.
Can I ask a question, please?
Yes, please.
Thanks for that excellent talk. Now, beta blockers are not useful, and it is harmful also if it is put in the night, right?
Yeah.
So, but then when we use Travacom, for instance, would you advise us to put it in the night? In which case the timolol part is not useful and it is harmful.
No, I always ask a PGA plus timolol combination to be put early in the morning. That is my standard advice.
Excellent.
7 a.m. in the morning.
Yeah, and I do the same thing, but I always find a lot of prescriptions.
It's
Travacom put in the night.
Personal choice, but I would always ask them to put it in the morning at 7. And second, when a patient is on beta blocker, I tell them the specific time, put it before 8 a.m. in the morning, before 8 p.m. in the evening, so that it is more in the waking hours, that 12-hour period. So if you don't tell that patient puts it one drop at 7 o'clock, another drop at 10 o'clock at night, they tend to distribute it very erratically. So it is a good practice to specify the time and say, though it is not exactly that time, half an hour this way, that way, I want you to stick on to.
Ma'am, I have one more question.
Yeah.
It's regarding the repasodil only, though it's not the medical management. I'm talking about, do you have any experience of repasodil using the post-operative period? Do you think it helps in a wound modulating, And certain reports we came across, they show its help in a wound modulation,
Yeah.
especially post-trabeculectomy or post-AGV also. So what's your thought?
I have read these reports, but I have never tried it in my practice because the ocular surface side effects of these drugs are so common and so significant that I would not want that to complicate the post-operative course of my patients who have undergone trabeculectomy. The redness, the subconjunctival hemorrhage, I would not start Ripasudil for that purpose. Dr. George?
We know that endothelium over time does recover. It can take weeks, can take months.
Yeah.
I am really not convinced that Ripasudil is doing the trick
Yes, yeah.
because it doesn't work in every patient.
Correct, correct.
So it may just be that we gave multivitamin tablets also and he got better.
Yeah, see, we have to see what is the long-term answer. I mean, I think literature will tell us that in time. Thank you all.
Thank you, madam. Now let's move on to the next talk.